All right, so we're going to go ahead and get started. Welcome again, everybody. Thank you for being here today. This is a panel discussion on Roe v. Wade, what's next. The impact of the leaked brief from SCOTUS is still causing a lot of waves of panic and uncertainty across the country. Tonight, we're going to do our best to prepare for the worst while hoping for the best by our engagement and actions before and after the final decision of the Supreme Court. I'm Andrea Contreras. I'm a second-year resident in obstetrics and gynecology here in Texas. And I'm also a Copello Fellow with DFA, and I lead the Doctors for America's Reproductive Rights Committee, and which is part of the Health, Justice, and Equity Impact Area. Before we get started, I wanted to take a quick minute to invite you all to officially join Doctors for America. Being a DFA member today means taking the important and simple step of selecting a membership level and paying your annual membership dues to support the DFA organizational sustainability. There's 6 different levels to choose from, and a DFA team member will put the link to join in the chat. A few ground rules for this educational session. One, there's no such thing as a stupid question, so all questions are welcome, and please feel free to engage with your Q&A function. Speaking of questions, use the feature that we have, and we will go ahead and address your questions during the second half of our session. And we will also look out in the comments for comments in the chat box. And again, DFA staff will be sharing helpful links during this session. So today's topic of discussion is, first is the upcoming Roe v. Wade ruling. And we have, a diverse panel of different specialties, areas, and expertise. So I'm going to go ahead and start introducing our panelists. First up, we have Genevieve Grabman. She is the author of Challenging Pregnancy, A Journey Through the Politics and Science of Healthcare in America, which was recently published in March. Congratulations. A proud University of North Carolina Tar Heel. Did I pronounce that correctly? She also has a master's in public health from Johns Hopkins University and a Juris Doctor from Georgetown University. Her day job is as an attorney for United Nations agencies whose views and member states she absolutely does not represent. And her night job is being a mother to 4 children. She volunteers her expertise in public health policy and refugee law to organizations working in Afghanistan, Malawi, and Mexico. And she is a returned Peace Corps volunteer from the Kyrgyz Republic. Sorry. And she's, DFA members may remember her from her time as the director of the government relations for Physicians for Reproductive Health. Everybody, welcome to Mrs. Grabman. I don't know, Mrs. Grabman, can you tell I've been conditioned to say doctor before everybody's last name. Mrs. Grabman, would you like to just go ahead and share with us a little bit about your book and what that experience means and how that led to you being here with us today?
Sure. Just call me Genevieve. It's fine, or Jenny. Mrs. Grabman's my mom. So yes, I am really excited to be here, and thank you for letting a non-doctor crash your panel. I'm honored and grateful. And I do think that this is exactly the type of interdisciplinary conversation that we're going to need, certainly now and as we go forward, to get us out of this mess that we're in. Very briefly, because I'd like my distinguished co-panelists to introduce themselves, I did just recently publish a book where I describe from the time that I was diagnosed with a blighted ovum to the time when I tried to figure out whether it was possible to do a selective reduction, to the time when I found out that the pregnancy was compromised with twin-to-twin transfusion syndrome, when I found out that my pregnancy with identical twins was further complicated with selective intrauterine growth restriction, or SIGR, and a number of other complications, to all the way to trying to seek laser surgery, intrauterine laser surgery to separate the conjoined blood vessels of my twins, or possibly to even terminate the entire pregnancy because things were going south real quickly. to being denied all that care for all those conditions that I sought, while abortion certainly was still legal, especially where I am, to having to wait until the end of the pregnancy to find out who walked out of that pregnancy. Were there 0 people, 1 person, 2 people, or 3 people? And my whole point of writing the book and hopefully speaking with medical practitioners is for us to widen our lens and just talk about all the other things that will be affected when Roe v. Wade falls. And for us to have a conversation about whether this is our intent and what to do for the myriad of conditions that will no longer be able to be adequately treated. So that's my little spiel, and I'd love to hear from my co-panelists.
Thank you. Up next, we have Dr. Nancy Stanwood. She is the Chief Medical Officer of Planned Parenthood of Southern New England. For over 20 years, she has been practicing obstetrics and gynecology. She's a medical educator and an ardent advocate for reproductive health and rights, and I'm going to add justice. Her prior positions include board chair physicians for reproductive health, a national physician advocacy organization that trains and supports physicians to speak out for sound science and the needs of patients in reproductive health policy, and section chair of family planning at Yale School of Medicine, where she helped found the section and the fellowship in complex family planning. Now more than ever, she believes that physicians must speak out to protect the human rights and dignity of their patients. Dr. Stanwood, would you like to just go ahead and further introduce yourself?
Thank you so much. Thank you so much, Dr. Contreras. And thank you to Doctors for America for hosting this really important panel. I'll add that my pronouns are she, her, and that I'm a proud provider of abortion care and have been so for many years. I really hope that in our conversation today, I can bring the perspective of somebody who has provided abortion care and has taught other physicians to provide abortion care, and has also been a part of helping doctors think about being advocates, how to get the training to be an effective advocate, what does advocacy mean, and particularly what does it mean now in this new era that is fast approaching. Thank you.
Thank you, Dr. Stanwood. Up next is Dr. Andrea Palmer. She is an Oklahoma native turned Texan in 2016 when her family moved to Fort Worth. Growing up, the granddaughter and niece of surgeons, her decision to become a physician came early in life. Having wonderful, strong female role models gave her a passion for working with and caring for women, making obstetrics and gynecology a natural career. Dr. Palmer graduated from the University of Oklahoma and attended medical school and residency at Oklahoma University Health Sciences Center, where she served as chief resident. She practiced in Oklahoma City at Lakeside Women's Hospital, serving as the chief of staff for 7 years before moving to the not so great state of Texas at the moment. Dr. Palmer is married to another busy physician and has 2 school-aged children. She now practices with Venom Women Care at Baylor All Saints in Fort Worth, and she is a passionate advocate for human rights, abortion access for all, and the LGBTQ community. She recently published an op-ed article that was very interesting to read. Dr. Palmer, would you like to go ahead and introduce yourself a little bit more?
Yes, Andrea, thank you so much. I'm a less exciting pronunciation, Andrea, and I am an OBGYN here in Fort Worth. Just trying to figure out how to be an advocate as a private practitioner and mom, and somebody who's trying to provide patient care in the state of Texas, where, as everybody knows, our ability to take care of women has become just severely limited and restricted. I kind of got on this public advocacy train quite by accident. I actually had a friend who was contacted by NPR way back in September when this all went down, who is an employee of our local medical school, and she didn't feel like she could speak out kind of on a public way. And so she goes, but my friend Andrea has lots of opinions and I'm sure she's happy to share them. And so that has just kind of really spiraled into an opportunity to use my voice to speak up in whatever way that I can. And I've been very honored to be interviewed for the New York Times and on NPR, and the opportunity to write the op-ed for MedPage Today is kind of what landed me here. So it has been not a job that I wanted to have, because frankly, it's not a job that I think that we need to have, but we're gonna be here and speak out and try to make the Texas and really the country a place where women can get the care that they need.
Thank you. Okay, and thank you for those wonderful introductions. And we'll go ahead and start the Q&A, not the Q&A portion, but the moderated discussion. So I first wanted to start with a rather simple question, just so that we're all on the same page. Ms. Genevieve, if you might be able to speak to this a little bit further, but what does it mean to overturn Roe v. Wade, and how is that possible with this upcoming ruling on the Dobbs v. Jackson case that has, at this time is now infamous?
So we expect that the leaked opinion from Justice Alito in the Dobbs case will in fact be the substance of the opinion that will actually be released. We're expecting it any day now. There's 35 more cases that need to come down from the Supreme Court, and it ends its session at the end of June. So any day, the final Dobbs opinion will be released. We kind of expect it as the final thing, so the Supreme Court can hand this down and then trek on out of town. And so yes, Roe v. Wade is going to be overturned. That's not now that we've gotten over the initial shock, we now need to know what that means, and what that means practically for about half the country. It means that for those states that have laws that are ready to jump into effect, to spring into effect as soon as Roe v. Wade falls, it means that abortion access will be curtailed in a pretty substantial manner. What Roe v. Wade did is that it took away from the states the ability to decide whether abortion was legal or not. It made abortion legal throughout the entire country. The standard by which abortion could be regulated was, with Roe v. Wade, was determined by a trimester framework. That there was less regulation in the first trimester, more was permitted in the second, and definitely lots more in the third. That was overturned by a later Supreme Court case called Casey, and Casey put a different standard in. It was called an undue burden standard. And what that meant was that the restrictions a state put on abortion could not be unduly burdensome to the woman's right to be able to procure an abortion. And what the Dobbs opinion will do is it will get rid of that standard and say there's no longer a legal, constitutionally protected federal right to abortion, and that each state can decide what rights there are to abortion based on those states' own constitutions and laws. And so where this puts us as advocates, you as providers, me as an attorney, me as somebody, as a consumer of reproductive health care, it means that we as advocates have to start making the point. We need to look at the states where we are and to think about how could a right to an abortion be protected under perhaps a state constitutional right to life, to liberty, to privacy. If there's a state constitutional right to equality, could any of those be used at the state level to protect abortion? And then we need to fight to have that protection in the state courts. It's going to return us to the state courts. We need to start having these conversations where, if you read the draft opinion in Dobbs, you notice that they talk a lot about how abortion is no longer needed because, for example, we have places where we can drop off newborn babies at fire stations. But what is never mentioned in the Dobbs opinion is the effect of abortion on saving a pregnant person's life. And it's never really fully discussed in that opinion, the effect on being able to procure abortion for all the panoply of other health conditions that a pregnant person or a person who simply could have the potential of reproducing, could ever ever encounter. So we need to return the conversation to those things, and to find a hook for them in state constitutional law.
So I think it's going to be more important with the upcoming mid-elections that we really get all of our representatives out there and vote and make it clear that access to reproductive care is very vital for everybody. Thank you so much for that wonderful explanation. So, when Roe v. Wade gets overturned, abortion access will become a state issue. And so some states will have access to abortion while others will not. I know with the recent laws like Senate Bill 8 in Texas, we have seen, the surrounding states have an increased number of patients looking for care. Dr. Stanwood, Dr. Palmer, have any of your patients mentioned any concern with the possible SCOTUS overturn, or have heard of Senate Bill 8, or what type of preparations have you guys started placing?
I have had, here in Texas, obviously, this has been an issue since September. It's been amazing to me since that time, over the past 8 months or so, actually how few of my patients knew the extent of the bill and the fact that it might apply to them. Currently, right now, I have a person who's pregnant with a fetus who has trisomy 18. And of course, NIPT was done around 10, 11, 12 weeks, and amniocentesis confirmed around 14 or 15 weeks. And in Texas, she's done. She was done before she even walked through my door, frankly. She did not have the funds and the means to travel out of state, which is really the only option. And so she has been made to carry until she either has a demise or goes into labor, one of the two. And she was completely floored that the law would apply to her. And she just had no clue. She knew there was a new kind of abortion law out there, but she didn't have any inkling that it could apply to her in her situation. And so education of the general public, I think, is a huge hurdle that we have to figure out how to get over, because so many people are just absolutely clueless about the laws that are being passed that could potentially affect them on a daily basis. I will say, of those who are aware, my partners and I all have had a significant increase in consultations over the past several weeks of young women who have not had children coming in for a request for sterilization. And that has been Thursday, I'm doing a self-injectomy on a 25-year-old G0.
Wow.
So it's that's the new trend.
Wow.
Because they just don't want the possibility of an unintended pregnancy. And I've tried to gently remind them that IVF may be on the line too. And so, like, if you're thinking in the back of my mind, I'll be able to get IVF in 10 years when I'm ready, that may not be a possibility either. But the scare of an unintended pregnancy is significant enough that they want permanent sterilization.
Wow, that's very striking.
I've got to answer a call.
Wow, Dr. Palmer, that is really remarkable. And Dr. Contreras, I think this is a great example of the incredibly starkly different realities that are going to come about with this final decision, depending upon where you practice. Being a physician, particularly an OBGYN in Texas, it is going to be remarkably different compared to a state such as Connecticut, where I practice. And I guess I wanted to lift up one sort of messaging thing before I talked a little bit more about medical practice. And I'm not a lawyer, and if Genevieve wants to jump in and correct me, I think just one thing I want to lift up is that Roe is going to end. But we might hear things in the media about, no, it only just kind of changed a little thing. It's not really overturned. But any decision by the US Supreme Court that allows the Mississippi 15-week ban to go into effect is de facto the end of Roe. because, as Genevieve said, Roe and then Casey has this idea that you can't ban abortion before viability is where Casey landed. So I just want that to be really clear for the audience that any decision that allows the Mississippi ban to go into effect is the end of Roe. And that we don't expect that the decision will say anything like, well, not before 15, though. There probably won't be any gestational benchmarking, so that a 5-week ban would be fine. An at-conception ban would be fine. So that's as much of lawyery talk that I want to go into. I think when I look at what this means for the practice of medicine, I really see it in 3 different places. I see it first and foremost for patients. And then I see it for the patient-physician relationship. And then I see it for physicians. And your audience may or may not be aware of some of these things. So I guess I want to state some obvious things. Abortion is healthcare. Abortion is common. That 1 in 4 people who can get pregnant will have abortion care in their lifetime, and that 1 in 5 pregnancies ends with abortion care. And that when abortion is not accessible, it still happens at the same rate. Banning it doesn't make it go away. Banning it just means that it changes the stress, suffering, and sometimes danger that's involved for people in getting access to the care that they need. And I want to just be really clear about what are the options for somebody in a state that's going to ban abortion. They could be forced to give birth against their wishes, and then can decide whether they're going to parent or have a plan to adopt. They could travel to get abortion care in a place where it is not banned. They could access telehealth medication abortion. Or they could try to do something that is less safe or less effective. I do want to lift up that self-managed medication abortion, including people who are able to find the medication from reputable locations and manage the abortion themselves, that we know from good science that is safe. And this idea that somebody who self-induces with these medications is doing something dangerous, we know from the science that they're not. And that from a harms reduction model, that is the safest thing for them if they can't otherwise access care. I also want to lift up that this is going to be it's incredibly important to recognize that these bans are going to have different effects on different communities. And that for people of color, for Black people, Latina people, for Indigenous people, and for people living in poverty, that these bans are going to hurt them first and worst. That we already have significant health disparities around reproductive health care for particularly Black people. And that Black people have 2 times the morbidity and complications of pregnancy and 3 times the risk of mortality from pregnancy. And with these bans, that is only going to get egregiously worse. So that's really, for me, the lens of patients. I think in the patient-physician relationship, I mean, think about what that means to us. Think about that sacred space that is created in our relationship with our patients. And that this banning of abortion is going to change that. In places that are going to ban abortion, will our patients trust us to tell us their true stories? Are we going to feel like we're going to be coerced by the rules of the state to police our patients' reproductive lives? We do know that there are 5 states right now where it is illegal to self-manage abortion. But I want to lift up that there are currently no laws mandating reporting. And that actually, to report somebody self-managing an abortion to the authorities is a HIPAA violation. So in this Wild West that it's about to happen, I really want us to lift up that incredibly important patient-physician relationship and protect it in how we talk about what's coming next. And with that lens of reproductive justice, the idea of, are the states where we practice that are banning abortion, are they going to force us to become the police for our patients? That so much of the state already over polices Black and brown bodies, and our doctor's going to become the next tool of that. I think that we just need to be so careful. I also want to lift up that when we chart in the medical record, we want to be careful about what we put in there to protect our patients. We don't want to say, oh, well, she bought the pills off the web. Like, no, don't say that. Don't write that. You don't need to record any antecedents to what brought this patient here. You can say she presents with bleeding. And that to keep our patients safe, we need to be thoughtful and mindful about what we actually put in the medical record. And I think if I can, I know I've been talking longer, maybe the other people, but I want to finish that thought about, there's patients and physicians, and what does this mean for physicians? And that really, it means that we have to be advocates. And that's an incredibly important role. And I recognize that Dr. Palmer said, I didn't go to medical school to become an advocate, but we have to be advocates for our patients now. And that really, I want to lift up that advocacy is something that we are ready for. We already know the science and know how to speak about science in layman's terms. So that's a skill we already have. Sharing stories is incredibly important in talking about advocacy. And we tell stories every day. Think about sign out when you're talking about your patient's experiences to your colleagues. So we already have storytelling. And that really the level of advocacy, it doesn't have to be going to the White House and talking, but some amazing physicians were able to do that at a roundtable recently with the vice president. It can be at your institution. These legal changes are coming. Institutions are going to need to write new policies. You should be in the room helping to write the policy that really protects patients' rights and allows for accurate counseling and timely referrals. It could be at the local level with your local medical society, your state medical society. Get involved. These organizations might be taking positions. You can help be a part of that voice. Particularly lifting up to protect the patient-physician relationship. At the state level, if you're in a state that is going to lose access to abortion care, you can advocate against those harmful laws and regulations as they're getting written, and then after they go into effect, because they probably will, you can advocate against them and talk about the harms that they cause for your patients. Patient stories are so critical to physician advocacy. And if you're in an access maintaining state like me in Connecticut, you can advocate to expand services, to expand material support for people to be able to travel there. And it's not just like travel, it's hotel, it's childcare, it's a stipend to make up for lost wages and for coverage of medical care. And you can see there's some states that are already moving in that direction. For people who feel like, oh, I don't feel like I could go and do that, that feels intimidating. These are skills you can learn. But if that's not your wheelhouse, if you are a researcher, there's going to be a giant natural experiment in our country, and it needs to be documented. So if you're in emergency medicine and research, track what's happening in your state. If you are a researcher in public health, look at pregnancy trends and outcomes. If you are in OBGYN, there are multiple opportunities there. And I think the last thought I want to sort of leave you with for physicians, as far as what can we do, if you are a physician who could provide abortion care, then look into doing it. If you're family med, internal medicine, OBGYN, you can provide medication abortion. It's safe, it's effective, it's simple to learn. That's something you could do to make access a reality for patients. And if you can provide procedural abortions, then do. If you're in a state that's going to see a surge of patients, I'm looking at you, Illinois, anybody in Illinois, then if you can step into that role of caring for the people who are going to travel there, then that is an incredibly important role to play. I don't mean to be like doomsday, but like dark days are coming. And that we as physicians need to work together and work with our allies in public health, in law, to really try and light the way out of the darkness and back into a more just future. It's what our patients need from us now.
Absolutely. Thank you so much, Dr. Stanwood. Guinevere, I think you wanted to say something. You had your hand up.
It went in one ear and out the other. I was so riveted by what Dr. Stanwood said, but I wanted to point out a little bit more about how Dr. Stanwood was mentioning and Dr. Palmer also were mentioning that we don't fully appreciate the scope of what is going to change for us. And what Texas is kind of our first shoe to drop on this millipede, right? And Dr. Palmer described how she has a patient who didn't fully appreciate what local law meant for her. And I think that's something, again, that we really need to be talking about, because it's not just, oh, oops, I got pregnant and now I want an abortion, which is like this somehow this crafted argument that is coming out of, that you see it like reinforced in the draft Dobbs opinion. It is all the other healthcare that is somehow touches upon the termination of a pregnancy or the termination of even an embryo or a fetus, right? And so that's where in my introduction, I described the challenges that people may have even in resolving blighted ovum. Because if sperm meets egg and that is considered a pregnancy, then how do people resolve a blighted ovum, even though that ovum is never going to develop further? Ectopic pregnancies have been much in the news, so no need to belabor that, but we know the catastrophic effect of prohibiting interventions into ectopic pregnancies. We need only to look at El Salvador and the excellent work, the research work that was done by the State Information Exchange 6, when they took a research project to El Salvador and they saw women in hospitals dying and waiting until they exploded before any physician could intervene in their ectopic pregnancies, or women in prison because they had a miscarriage that could not have been proved to be a spontaneous miscarriage, but was therefore presumed to be a procured abortion. So there's that. And then how do we go on with genetic testing? If there is a risk of, for example, of accidentally having a miscarriage when you do a CVS or an amniocentesis, are those permitted as genetic testing via amniocentesis or CVS permitted if it risks a fetus? Is that going to be permitted? And then what about, shall we continue on? What about anything, as I was describing fetal surgery, where you're trying to save a wanted pregnancy that has gone real sideways and real south? If there's always a risk when you do fetal surgery that it will, again, unfortunately end a pregnancy. That is not the intention of the surgery, but it is a risk. Will fetal surgeries be permitted given that known risk of terminating the pregnancy? And what about fetal surgeries where one fetus is sacrificed for the overall health of the pregnant person and the other fetuses, which was, again, the case that I was in? Will those be permitted? They weren't permitted to me, even for me. Will they be permitted for anyone in the future? So we need to start, again, thinking about the wider effect that Roe is going to have, and to start telling, again, these stories, and to think about some answers here for things that we do consider as just standard healthcare. We don't call them abortions. Selective reduction, that's a euphemism. It means abortion, but selective reductions certainly will not be permitted. So in many places, in many states, we need to start stripping away the euphemisms, start describing these things as they are, and to start thinking about what are the workarounds and how do we maintain the lives and health of our patients.
Agree. It seems like it's a slippery slope. During that conversation, you guys brought up a great point. You know, a lot of our patients, like Dr. Palmer's patient, and I've definitely experienced this as a resident as well, where patients aren't aware of the laws and how it would affect them. Do you guys feel that moving forward, we should start counseling women regarding these laws during well woman examinations? You know, when they come and complain of like vaginal discharge, should we already be talking to them about, well, if you know, this is your state law, be careful, make sure you're, you know, not having unprotected intercourse if you're not trying to get pregnant. Should we, you know, prescribe Plan B for them ahead of time? Should we prescribe, you know, mifepristone ahead of time? Can we, you know, what are your guys' thoughts on that? Or how
Yeah,
should our
I've def-
counseling change? Yeah.
Yeah, I've definitely upped my counseling game. I mean, of course, I've always been a huge fan of contraception. But at this point, yes, whenever I see a patient for any given complaint or situation, not just their annual exam or birth control visit, making sure that they have contraception in place if needed, reminding them that in Texas, Plan B is behind the counter, but not prescription required, so that they can go ask the pharmacist for it, but they don't need to wait for the office to open if it's over the weekend to call me. I am, yeah, I've definitely increased my pushing of long-term reversible contraceptives as a more effective means of a contraception for patients. And even for some patients, and for, well, anybody really encouraging using two methods of pregnancy prevention at this point, if a pregnancy is just not a tenable situation for you. One thing that I do want to mention, we have definitely in my practice had women who have come in for missed abortions, and let's call them a missed abortion and not a miscarriage, because again, we're euphemizing the whole situation, who have been denied misoprostol at one or more pharmacies locally here. And so now with every, and it's been, you know, how they come in waves, I've had 4 in the last 2 days. But I've, with every misoprostol prescription I am hitting the patient my cell phone number, and I am not a giver out of my cell phone number to patients, and saying, if the pharmacy is not giving you the medication, please call me immediately on my cell phone, no matter when it is, because a patient who is grieving, again, the loss of a pregnancy, like the last thing they need is flack from some pharmacist who thinks that you know, they know better and that they're trying to institute their level of control over this person. It's just unacceptable to me. So I always said, I'm ready for a fight, call me. But I've been giving my cell phone number out with every meso prescription written since, well, for the past several months.
Yeah, I can see you're ready for a fight. And I'll add on a thought that just came to me as you were talking. You could stock misoprostol in your office and dispense it from there and help your patients avoid having a bad pharmacy experience. Just a thought that came to mind. But
yeah, that's a really good idea, actually.
I think the other thing that comes to mind is to really center preventative care and preemptive counseling, and that definitely includes patient-centered, patient-driven contraceptive decision-making, be that for a LARC or anything else. That also includes letting them know what the law really could mean for them. Maybe having a handout about it in your office that you give to everybody who can ovulate. And it also means preemptively letting people know, if they're in a state where it is banned, how they could access self-managed medication abortion. Let them know about aid access. Let them know about Plan C. If they think they need to travel, let them know that there are abortion access funds that could help them financially. I think that we really need to have a harm reduction model, and that is something that might be shocking for domestic physicians to think about, because, you know, harm reduction, isn't that a developing world thinking when you're there? Like, no, this is us now here, in order to help our patients be as safe as possible when the changes in law are going to put them in positions to be unsafe. we need to try and help them remain as safe as possible.
Thank you. Okay, so I'm going to shift the conversation a little bit towards physicians. So how do you think that these laws will affect physician training? I mean, Dr. Stanwood, you know, I've had some personal experience with this, but would you care to elaborate more?
Thank you. Yes, and if it's okay to share your story, Dr. Contreras, may I do that?
Yeah, absolutely.
Dr. Contreras' residency program reached out to our residency program from Texas to Connecticut after SB 8 happened in September to say, we have some residents who want to have training in abortion care and they can't get it here. Can they come get it with you? And we set up the necessary process to allow for that. And it was an amazing 2 weeks. It was only 2 weeks, but it was really intense 2 weeks to have you on our service, helping us take care of patients. In OBGYN, our ACGME requirements are that people in training have access to abortion care. I don't know what it means when half the country is going to ban that. That's going to be a huge change, because I'll lift up in our 2 programs, we had to have a program letter of agreement from one residency program to another, and that was a process of drafting it and making sure it was okay with both residency programs and both GME offices and getting it signed off and having that paperwork. You can't do that for every single residency program that is going to no longer be able to give their trainees access to abortion care training. We can't send half of the residents to another part of the country to receive this care. And I think what this means is that, again, lifting up on what Genevieve was saying about, this isn't just induced abortion care. This is every other part of medicine that touches. So that when people don't get training in induced abortion care, they don't learn the counseling skills, the procedure skills that are required for that and all the other circumstances where those skills might be necessary. I think the other thing that's going to happen, that's going to be really, so, and let me just say that then we're going to have a whole generation where half of the OBGYNs, and I'm just saying half roughly, I don't know exactly how many residents are trained in states that are going to ban abortion versus states where it's going to be maintained. But you're going to have a huge chunk of people graduating from programs where they didn't get that training. You're going to have this generation of half the OBGYNs without that training and that perspective. So what does that mean for access in the other states? It is going to have a significant impact on what our patients can expect from our profession in the next generation. And unfortunately, it means that they're going to have to expect less because the education is going to be less.
Thank you. I think it also brings up issues with residency or resident mental health. You know, for example, for myself, it's important that I'm able to provide these services, and not being able to do so can be distressing to a certain level. So I wonder how many other residents share that same feeling or emotions that I do. Speaking of emotions,
I'm sorry, if I can just jump on there. I want to say that the moral distress that is going to hit the profession of medicine is going to be shocking to people. And Genevieve, I really love the phrase that you use, it's the first shoe to drop of the millipede. That, yes, I think about the attendings who were near the end of their career when they trained me, and they shared with me their stories of what it was like to be a doctor before the Roe decision. And their stories haunted them. That is what's coming next. We're going to see the harms that this is going to do to our patients, and we're going to still have to be their doctors. And the moral distress that this will cause, I think, cannot be overestimated.
And I think when you piggyback that on top of the fact that we are still in and have been in a pandemic, and we all know the impact that that has had on the level of job satisfaction, burnout, mental health of everybody in healthcare. OBGYNs have not been excluded from this pandemic. We've had patients dying and pregnancies ending, and it's been brutal for us. Not as bad as the ICU nurses. Those people will never be the same, ever. But you know, you add this extra layer of helplessness. You add this extra layer of you know, just being told that we can't do our job the way that we know how to do it best and to take care of people. I think that the level of burnout is going to just exponentially increase, and I think it will drive people out of medicine. I mean, there's self-preservation will kick in at some point, and I think that people, you know, it's gonna be interesting to see if there's a mass exodus or not. But it's hard.
Yeah, if I can jump off of one thing there, absolutely, there's definitely a sense of helplessness, but I guess I want to remind us that we can still take action. And I will say for myself, part of what led me to wanting to be a physician advocate was to have a constructive outlet for my righteous indignation. So it's normal to feel confused and angry and helpless, but try not to stay in that helpless phase very long, because taking action is a way that you can relieve, or I know I can relieve, my moral distress. So becoming an advocate or providing care or both, or any way that you think you can be a part of the movement that is going to push back against the darkness, that's going to be really important.
Agreed.
Finding a constructive outlet for my righteous indignation may be my new motto in life.
Ditto. So I'm going to take a question from the audience. Suzanne Knapp asked, if a husband or father of an unborn child does not want for a woman to have an abortion, are doctors okay with letting the woman take the initiative to gain an abortion?
Yes.
Can I just weigh in on that one? So, okay. I will say that there is a little bit of a twist on this in Texas, right? Where we have this vigilante law where if somebody suspects somebody of getting an abortion after 6 weeks, then there is it's not that the woman can be reported, it's those who could have helped the pregnant person procure that abortion can be reported. But there's no law that I am aware of currently on the books that says that the sperm donor in this instance of a very early pregnancy can block that person's medical care. Now, there are all sorts of privacy requirements, as Dr. Stanwood mentioned, where I don't understand how the person who is equally responsible for that pregnancy would know what is happening in between the pregnant person and that person's doctor. But there is concern that, say, I'm in Texas and I have procured an abortion and it is 7 weeks or 8 weeks, and I tell my partner that I have done that, and then the partner decides to take action against, the Lyft driver who drove me to the hospital and the doctor who helped me notwithstanding the law and everybody else in the practice that assisted with providing me care. There is some real concern there, and whether that person could take advantage of the reporting law in Texas. And then those laws are also, the stuff spreads like a virus. So bad law spreads, and this bad idea is spreading to other states. So there are some open questions there, but I would say that currently there's still medical privacy that should be protecting the provider-patient relationship.
Okay, Thank you. Another question. Has anyone heard of the AHA has plans for 2 separate ACLS guidelines for red state and blue states regarding the perimortem cesarean, one of our euphemisms for everyday life-saving abortions?
No, I haven't, but I will say that again, this is just an example of some of where the shock waves are going to go that nobody thought of, that now we're going to see. Dr. Contreras, I will say, I think there was also one question ahead of the most recent one in the Q&A.
Yes. Can anyone speak to how we can best help our military service members in states where abortion rights are being restricted?
Well, I mean, I live in DC and we're about to experience a very similar situation here, right? Because Congress determines what rights we have. And when we have a restrictive Congress, we don't have many rights in DC. Similarly, so those of us, those serving the military, their health care is often restricted with respect to reproductive health and maternal health and abortion care. I think this is where we have to do some creative thinking, and also there's the awareness that Dr. Stanwood and Palmer were speaking of letting people know about abortion funds and about abortion travel funds, because really women or pregnant people from DC, members of the military who can't access abortion care where they are, will be forced to travel to someplace where they can.
Yeah, and I'll lift up, I think part of the added concern is that you can't just tell your commander like, hey, I'm going to leave, I'll be back in 3 days. That there's a very rigorous process to need to have a medical leave of absence that might require needing to disclose why. And I'll just lift up that there was an article, I'm sorry, I'm not going to remember the author's name or the outlet, but I read it in the last week about somebody who had been in the military, was a victim of sexual assault and became pregnant from the assault, and wanted to have abortion care, and lifted up the idea that for people who are survivors of sexual assault and want to report in the military, it still is within their chain of command that they have to report it, and that it is investigated within the chain of command, including if the person who they accuse of rape is within their chain of command. So I think that's another significant issue for a reproductive injustice for people in the military.
Thank you. All right. Do any members of our audience have any last minute questions? All right. What first-line policy needs to be brought to state medical societies, specialty societies for the AMA?
I would only, again, putting on my law hat, right? That's beyond the AMA, but I again would ask for us to look for some of the clues that are in the Dobbs opinion, right? About where, if there's no federal right to privacy, because, so without getting into all real legal techie on you, there's what Dobbs found is they found specifically there's not an abortion right, and the abortion right had been found under a right to privacy, which was found under the penumbra of liberty. So Dobbs is also saying there's not a constitutional right to privacy, federal. My sense is that everybody wishing to provide private reproductive, maternal, abortion care needs to start looking at every state to find out what rights do exist in those state constitutions, and to use those rights as the hook to hang your hat on, and to frame the care, the necessary medical care that you give, and the practice of medicine and the doctor-patient relationship in the language that is constitutionally protected in each state. That's the only way that those rights will be able to survive state scrutiny in state law. So start analyzing where you might find a right and frame your arguments and your policies within the scope of that right.
Okay, so we will be doing a little something right now. Angie's gonna, sorry, that seems very menacing. Angie's going to be putting a link into the chat. This is our health advocacy alert. It'll take you to a link where it can give you direct action as to something that you can take. Angie, I don't know if you can go ahead and speak up. Is it going to be like a call to legislators or an email that we're linking?
Absolutely. I'm going to stay off camera here for a second, but what I'm going to put in the chat is a link to our action center. And so, talk is cheap. Now is the time to act. This has been just a life-changing session tonight. And so we all have the opportunity to do something. So you are going to you'll be directed to Doctors for America's Advocacy Action Center. And in the chat right now, there you go, I would encourage all of you to go to the link and you will see abortion is a healthcare right. And we need your help in protecting abortion access. So click on where it says abortion is a healthcare right, and it will take you to a script, a letter that you can personalize. So the basic letter is there. You don't have to put dear Senator or Governor, and these are for our state legislators, because as they mentioned tonight, this is going to get kicked back to the state and they need to hear from physicians. So this is your opportunity to give them help. So personalize it if you want. If you don't feel like personalizing, just click send. It will immediately send to your senators and representatives and to your governor. So let them hear from you as well. And you can, there's also a click to tweet and a really great, you're going to get an email too that will have some other tools in our tool chest that our very own Dr. Andrea Contreras put together, this fantastic toolkit that can help you with talking points and other things with colleagues and friends and get on social media. So thank you for that.
Thank you, Angie. So as we learned today, one of the things that we can do is try to advocate for our patients and really put on our advocacy hat. So DFA has this platform where it makes it really easy to contact your representatives. So I encourage everybody to go click the link, go in and send that email. It should be super quick and easy. So that way we can really end our session with, walking the talk. So if everybody has the link, I'm just going to go ahead and continue with our conclusion statements. So again, thank you everybody so much for being here. I hope y'all enjoyed it as much as I did. And thank you again to our panelists for taking time of your day to have this conversation with us. So quick reminders, we went ahead, we have this asks for you, so just go ahead and click that link. The event is available for viewing later on on DFA's YouTube channel, Forever Immortalized. And just please take 2 minutes to complete our survey so we can learn more from you about what went well, what sessions you would like to see in the future. That link will also be in the chat. And thank you all for being here and for everything that you do on behalf of our patients. We hope that you'll become an official DFA member today and take a look at the benefits of membership on our website. And the number one reason doctors, medical students, and health advocates join FDA is to be with like-minded people that share same values and priorities. So this is your tribe. Please remember to follow us on Twitter, on LinkedIn, and Facebook, and stay up to date with all of our programs, events, and other ways to get engaged. And again, thank you all so much for being here with us tonight.